Hi, this is Dr. Toby, your host on Health and Wellness. What a delight and an honor to have you on our show. We're so privileged that you're here to see this show with Dr. Charlene Collier. Dr. Collier is an obstetrician trained in some of the best Ivy League universities in the country, did her undergrad medical school at Brown in New Hampshire, went on to Harvard to do a master's in public health, and then after her residency at Yale University in Connecticut, and post-op, she went up to do a 2-year fellowship in maternal health with another master's in tow. She's been working in the Mississippi area, the director of the Mississippi Perinatal Healthcare Collaborative, and she's worked also at the University of Mississippi Medical Center. She is a delight to listen to. She's a mother, she's a wife, she's a daughter, she's a sister, she's a physician, she's a public health advocate, and she's an obstetrician who cares for her community. You don't want to miss this. Jesus is Lord. Almost done. Hi, this is Dr. Toby, your host on Health and Wellness. Thank you for joining us. Don't touch that dial. I have a special one-on-one with a public health obstetrician, mother, wife, physician, advocate, and daughter, sister too, child of God. She's been in the public space for maybe at least 10 years working in the public health industry to help reduce maternal mortality. And many of you don't know this, but America has the maternal mortality statistic of a third world nation. Compared to other Western nations, we're at the lower rung of the maternal mortality. 34.9 or 36.9 women die in America per 100,000 births, and that is a third world statistic. And when you look at the African American woman, we're talking of 69.9 women who die with secondary to 100,000 deaths. So we're here to learn, we're here to see what we can do to change that paradigm and move that needle. My guest, Dr. Collier, went to Brown for undergrad and medical school, went on to Harvard for her master's in public health, and then finished up at Yale University with her residency in obstetrics gynecology with a 2-year fellowship, and ended up with another master's, and moved to Mississippi to help reduce the maternal mortality. So let's talk about maternal mortality in the South. We have, maybe we'll call it a triple threat: obesity, heart disease, and I don't want to use STDs because it's not just Mississippi and Louisiana, but we have the highest numbers. When we look at the numbers for STDs, I think a statistic came out last time and said syphilis had a 900% increase. So do you think there's a correlation with obesity, heart disease, STDs in the African American community or in the South and maternal mortality?
You know, I think all of it together just adds up to the results of when a population's wellness and health have not been protected or prioritized, when you haven't invested in, there haven't been investments in community development to give those opportunities so teens have other things to do besides, you know, being exposed. That there's healthy food and nutrition, parks that are being developed. We can look very carefully across our state and the places where grocery stores go and don't go. Those are choices. The places where parks are built and they're not built. So those disproportionately affect black communities, and that we know is tied to a long-standing history of racism, segregation. You can put these maps. They're all the same map. You know, if you look at the maps of slavery, segregation, obesity, infant mortality, they all fall in the same thing. So even though that made people like, oh, that's hundreds of years ago, you know, but it was a cascading. It wasn't that long ago when there was, you know, segregation, separation, or even our health system. We both, you know, worked at university hospitals. You know, we have doctors alive today that remember patients going through different doors, right? So this is not a new, it's not an old enough problem that we've solved, that communities' health have not been prioritized. We haven't fixed the impacts. of racism. Even if you stopped it today and there was no more, the impact of it is still there. You know, we know how long it takes after a hurricane to recover, right?
Right.
We have not recovered from those insults of the past, and they show themselves, and we've not done the work of what does it take to keep a community healthy. And when you see STD rates skyrocketing, to me what I see is, you know, that education isn't there, the access to health care for young people isn't there. Then you're also looking at those opportunities. Like, are people living in a community where they're being encouraged, like, hey, you've got a future ahead of you. You've got, you know, you need to take care of your health. We're not taking care of men and boys. Let's just be honest. A lot of these conversations center around women, and boys and men are left out of the conversation in terms of sexual health and reproductive
That's
health.
true.
It's just the mom that gets pregnant,
Right.
but she's living in a community and has a partner whose health is also not being at all addressed. Like, where can, I mean, it's sad to say, you know, many black women get their first health care when they're pregnant, and too many of our men get health care the first time if they're institutionalized and not getting access to community health. So we need investments at that level. So I do think they overlap. They're all reflective of the same kind of root cause of that, you know, black population's health have not been supported enough. But
So education, resources,
the resources,
access to care, supportive environment.
and I think it's just really building up our communities to care for ourselves. Like, I think people need tools to feed each other, take care of each other. I think it's within our own communities. It's not always about somebody coming in and rescuing, but people need those tools to be to develop their own community up and take care of each other. But those resources do have to be there. It's much harder to do without resources, for sure. But we know that when we lift people in education, you lift them out of poverty, a lot of these problems go down, right? They all go down. It doesn't solve it completely because it's a bigger problem than that. We know that, you know, even for black women, having an education, having money doesn't 100% protect you. It does reduce the rates by some. It doesn't 100%, and that's where it's, are you being listened to? Are you being valued? But I will say, we need investments in public health. Like, we need schools to have health systems. We need the churches. It should be embedded in our communities, not locked up in just hospitals, you know, and the less we have of that, the less, you know, it's that someone has someone in their church, they can go to a nurse, or those in the school system. We're going to see more of that just because it's
So,
just hard.
From your experience with the Mississippi Department of Health, the death of patients, the statistics say three-quarters, I think three-quarters of deaths are preventive.
Yeah, very high
preventable.
percentage
Yeah.
we consider preventable.
So 4 out of 5 pregnancy-related deaths in the U.S. are considered preventable.
preventability is
That's
yeah,
a statistic that alarms any listener.
it does, and some people hear it and think, well, the hospital or doctor could have done something different. That's not what that always means. That means, like, is there some change that might have helped protect this person? And sometimes people look at preventability all the way across the life course. Sometimes they're looking at the health system. You know, if this person had insurance, maybe they would not have gone without care, and then they would have been, you know, going to the doctor before they died. So that wasn't maybe any one person's fault. That's like a policy issue, right? Then there's literally, like, the doctor they think did something wrong, but it doesn't always mean that. Preventability says, is there a solution out there? Is there something we could do that if everybody did it would reduce the deaths? And that's kind of that bigger picture. And we do say, yes, if it's a hemorrhage death, we know there's steps that you can take to reduce that chance. And if a place isn't doing those steps, we'll say that would have been preventable. High blood pressure. Again, I've never reviewed a death where I just said, you know, there was nothing we could do because she was obese. Never. She was just so big she had to die this year. That is not, I've never said it, never thought it. I have thought, she had so many comorbidities. Why did she finish prenatal care and not immediately have a family doctor? Why did anybody make sure her blood pressure medicine was filled, or that she had the insurance to keep her blood pressure going? Why did no one ever get her in with a nutritionist? I mean, that's a big gap. Now, you can't fix obesity in pregnancy, so we're not going to throw our hands up and say these women should die. Absolutely not. What we should do is make sure the health system can address it the best we can. Now, certainly things
Right.
are challenging. You get, yes, you have heart failure. You do the best we can, and sometimes the preventability is going back to the community and education. But people have responsibility at every level. You know, what the individual does, what the choices they make, but it also goes out to our whole, society and what we can do. So,
Wow. So where, I mean, you talk a bit about food deserts, but there's also what we call hospital deserts.
mhm,
So, for example, in Mississippi, I think you quoted this and said 3 hospitals in Mississippi have closed in the last 1 year or stopped offering OB services. And you said is that over half of Mississippi counties are maternity care deserts.
yeah. I mean,
What does that mean?
that
Half of
means
them are maternity care
that means
deserts.
there's no obstetrician in that county. There's no person, obstetrician, certified midwife, who can provide prenatal care or obstetric care in that county. So that means every person who can become pregnant will have to leave their own county to seek care. So that's considered a desert. For many, it's traveling 30 minutes or more, an hour, 2 hours, as I mentioned, and that is in all circumstances. Minor, you're just going for a prenatal visit, you got to drive 2 hours. Labor, your baby's coming, you got to drive an hour and a half, 2 hours. Or if real emergency, where you don't have that kind of time. In obstetrics, things are fast and they're dangerous when you're sick, and those distances are absolutely deadly. How do you solve that is also a challenge because you have a rural community. You know, how do you recruit a physician with $200,000 of debt and a spouse they're trying to find and children they're trying to educate to go live in a rural community? That's very hard. It's a challenge you have to fix. There are ways that it could be done. We certainly have the health department locations they used to provide prenatal care at health departments. Budget issues got in the way of that. I believe they're trying to bring that back. So, we need these layers in our community. It can't just be,
So EMTALA
yeah,
makes it mandatory that if you show up in an ER,
yeah, they have to
you
take
have
care
to
of
be
you.
treated.
Yes.
But you're saying that there are some things the ER doctor cannot
Oh
do.
no, a lot they can't do. I mean, if you need a C-section in that moment, you need a C-section. If you have a baby who's needs a respirator and to be intubated with the tiny tubes, they have to be at the hospital when they're born and their risk of death. And that impacts a lot of babies in rural states like Louisiana and Mississippi. If you're not born in a hospital that can take care of you or that baby, your risk of dying goes up by quite a lot. So
Wow.
we're struggling on a lot of levels. I mean, I'll say it, not expanding Medicaid had a big impact in Mississippi because that's what pays the bills, and if a hospital can't pay the bills, they'll close, and we just seen that, and that had a big impact in our state, and we're continuing to watch it happen. And the people who suffer are going to be more black communities, more poor communities first, because they're in those populations. So,
Well, we
yeah.
had a win last few months ago. They expanded the time for
Postpartum
Medicaid.
care, yeah. So that was a
12
win.
months. Okay.
It's exciting.
And you supported it and
Yeah,
was
certainly.
glad
Many
for
did a
your
lot of
support,
work
yeah.
through the health department. Other people worked really hard on that. It doesn't solve the problem. It's kind of the keys to get in the door, right? Like you have the keys now. When you open it, what happens when you get inside? Do you have a health system that's prepared to take care of you? So that is, obstetricians don't do a lot of care in those 6, 9, 10 months postpartum. That becomes more of a family medicine. They're looking at chronic health conditions. So what has to happen is the care of a pregnant person in that postpartum period is not just about obstetrics. It is about overall health.
Overall health,
What should be happening is a handoff from that OB
right.
to an internal medicine doctor, cardiologist, family
medicine.
doctor. The family doctor has to know about pregnancy enough to say, yes, she's at real risk of having a heart attack, because that happens a lot. We see ER docs or internal medicine say, oh, you're young, you'll never die of a heart attack, and shocked that this 25-year-old will die of heart disease. We know as obstetricians, but we're not the ones doing the care 6 months out. So we need that better education on both sides. But it has to be a community experience. Pediatricians do a lot frontline. They're taking care of babies. They see that mom before them who's looking depressed, who's looking like, she has a medical condition. So we need that We have the insurance now, but insurance doesn't solve the problem if people don't have a healthcare provider, if they don't have access to one. They're still back to work and need to drive 2 hours to get to a doctor. It's not, so not enough. So we need to use telehealth systems. We need to be more creative. If you just need a blood pressure check, you don't have to drive to Jackson to get your blood pressure checked.
Right.
You need to get it checked at home and have somebody close that can, somebody who can review it.
Monitor
Oh yeah, we got technology. I mean, there's so many things. If Amazon can drop you off something, in 24 hours, I know people can, get their
what's
blood
the one they
pressure
use
checked.
now? You can fly it on
The drones,
the
right?
drone,
We have
right,
a lot of technology. We should be using that for our rural communities. Should be the focus. If I'm using telehealth, it's just because I want to make my life more convenient because my doctor's down the street.
Right.
People who really need it, need to have access to those resources.
Yeah. What? I want you to give me 10 most common pieces of advice you give your pregnant women.
Yeah, 10. Okay,
If you
let's
have
see.
10, I don't know if you have up to 10.
Oh yeah, I can come up with 10 for sure. So, when someone is pregnant, I think one is finding a provider that they trust, someone that they can either grow a relationship with or who they have a feeling that they care about them. And a lot of times our gut intuition is true. If someone's not looking you in the eye, if they're not answering your questions, if they're rushing you, if they don't remember your name, if they don't look at your partner, if they blow you off on something you're really concerned about, believe that. Believe that feeling that that person may not be the right one for you. It's not always easy to switch doctors. It's not always possible. But when you can, you want to think about that if it is an option for you and to find someone you really trust. Even if you don't have someone you trust, all doctors have a responsibility to take care of their patients. And how do you get a doctor you may not have that connection with to listen? I say write things down. I'm a huge fan of a notebook at every visit. Having that piece of paper. When you come in with 5 questions, it's like a captive. It's a thing that we have to answer the 5 questions. Now, if you don't have them written down, the minute you pause, the doctor will be like, okay, I got to go. They'll get out the room. But if you walk in with 5 questions on a sheet of paper, chances are those 5 questions they got to listen, So that's a trick. It's not a trick, but I say, have them tell your doc, I have these questions I want to ask. I got 5. And they will sit even if they're running late. But if you try to remember, you're going to pause, you forget, and they will rush. It happens. Bring somebody with you. That's another one. It can be grandma, auntie, sister. We have doulas are big, new. They're not new. They've been around a long time, but a lot of focus now on doulas who are birth support people. They're not medical, but they're really trained to support a pregnant or birthing person. And for black women particularly, they tend to focus on advocacy, listening, making sure they're heard. When you're not alone, you have someone else who can say, hold on, doc, you said this, or can you go back and repeat that, who heard the advice that was given and can remember for you because you're overwhelmed, who can speak up on your behalf and say, no, you really wanted a vaginal delivery and they're pushing you to a C-section. Maybe we need to talk about this. So having an advocate with you is another big one. Really, really important to get the best care in our healthcare system. Self-care is another big thing. I try to tell patients they got to keep their peace in pregnancy. They can't take on every battle, take on every argument with their boyfriend. I'm like, your job is to really try to, if you can, take those moments to deep breathe, find that time alone. It is as important as taking medication to me. So I'm like, this is medical advice. You need to rest. You need to put mental health is so important, and we sometimes put it off like, well, I'll take my meds, but I'm just gonna not, I got to run around all day. That blood pressure doesn't come down. It takes that time. So even if it's 30 seconds of deep breathing in the car before you go into that job or before you step into that house to take care of your kids, and you just take that 1 minute, and people won't do the 1 minute. I've asked patients, like, take deep breaths for 1 minute, and they're like, can't do it. It's hard. But taking those times together to really manage that stress as best as you can, getting that. So that's probably the next one. I wish everyone had a therapist. If you need one, get one, or support. It doesn't have to be a counselor of some form, like somebody,
a social
worker, a therapist, a counselor, your pastor, someone you can talk to, especially. But if you have a clinical condition that needs, treatment for mental health, to get it. There's a lot of stigma there. But I try to destigmatize that because we actually see higher rates of preterm birth, higher rates of low birth weight. So there are real medical consequences to untreated depression. And sometimes we think about postpartum depression, but a lot of folks depressed at the beginning of pregnancy. So we have to think about that too. And I try to say, well, even if you're not looking for, a lot of people are very hesitant about medications. And I'm not saying you have to do that. You can get support. There's a great program in Jackson called Mommy. It's spelled like MOMME, and they were putting me back in mom, so they were focused on themselves. But it's a maternal mental health support group. It was started by two black mothers, sisters. One experienced severe depression postpartum, and she's created an amazing community. And many moms, they just get that, and that helps. They just get a peer advocate to listen, and some go all the way up to needing therapy. So I'm very glad to see it's become a lot more comfortable to address that. I'm up to 5 or 6. I'm big on water and food. Like, I will talk about nutrition. Okay. We got to talk about the nutrition. You got to drink water. I tease my patients if they come in my office and I don't see the water bottle. I'm like, where's your water? I teach them how to tell if they're dehydrated. That's a big component of getting enough healthy hydration. So not the sugary drinks, not the caffeinated drinks, but I teach them, like, okay, check your urine colors.
So like 3 bottles, 4 bottles,
Ooh, we get up to 6 sometimes, but we're making sure that they're, having access to that. A really important law just passed around pregnant people in the workplace, and that employers have to make accommodations for pregnant people. So if your job is telling you you can't drink, you can't sit, that is against the law now, and you should know that. You can't go to the bathroom. That is illegal, okay? So you have a...
Is it a state law or national?
It's a national. So it is. It's a labor law. It just passed. So it's something to look into. If you're at your job and they're not letting you do basic accommodations, you're at a cashier and you can sit and cashier. You can drink a water and cashier or go to the bathroom. If you're at a place that's really not letting that happen and you're pregnant, that's considered kind of a discriminatory practice.
What if you can't sit? What if your job, like pharmacy techs, they can't sit?
Yeah, they can't sit. So if you need a quick break,
and you're pregnant.
They need to make some reasonable accommodations. If you're still able to do your job and you just need these little...
Because I know we don't recommend them standing 6 hours
Right,
or more.
And so we just need them to do, okay, we let you take your 5-10 minute break and come back to work. We switch up your role. So it's just having those readable accommodations. Of course, when you're 6 weeks pregnant, it's very different than when you're 36 weeks. So a lot of this is towards the end of pregnancy. But I think it gets to that kind of kindness and support for pregnant people. Are we really being a village for pregnant people? And America's rough on pregnant folks. Now, you look at all these things we're asking for compared to like a European nation where people get a year off
after delivery,
postpartum, they get a midwife at their house, they get all kinds of stuff. The little 12 weeks we scrap for is not comparing. But then we look at our outcomes and they're very, very different. The breastfeeding rates are much higher, which is, of course, if you're home with your baby and you don't have to run back to work, but they have different social network than we do here. So here we have to think about that.
So Mississippi just passed the 12 months Medicaid law. So does that equate to 12 months work leave?
No, it really is just about having your doctor. You can keep getting medical care. So you have Medicaid when you're pregnant. When you have it's actually great coverage. Our Medicaid patients, if you have Medicaid when you're pregnant and I want to send you to a cardiologist or I want to get you see a neurologist, you can get all those things and they get covered. 6 weeks out, it was all ended for most of those patients. Some would roll into other programs like Just for Birth Control, or some were actually poor enough to continue with state Medicaid, but very few. So now we're saying, okay, do you continue to have health insurance, right? So what do we do with that now is the big question. If our system kind of is not welcoming to a 6 months postpartum patient, if they're not scheduling the visit, then nothing's going to happen. So we need to actually have action around what is the right amount of care look like for that year postpartum, because it hasn't been done before, and it definitely hasn't been done on a big scale. I think family medicine docs, those like you who've done some OB, are the best ones to take this on and really lead this, because you see that that long-term health perspective. And at some point it becomes less about just reproductive health, obstetric health. It becomes about heart. It becomes about weight loss. It becomes about, and that's where we need that collaboration. That as an OB, I knew all those problems very well in pregnancy. Now I get to,
Well, the
share.
challenge is that 30% of American women call their OBs their primary
Yeah,
care.
yeah.
So when they finish delivery, they expect you to be the one who takes care
So
of
we'll
everything
need guidance
else.
for that. And I think ACOG, our professional organization, will provide guidance and expectations. Even the insurance companies, they want the medical home with the OB. We just have to give those opportunities. So instead of seeing that person 6 weeks postpartum and saying your next visit is a year later, let's bring her back in 3 months. Repeat
Right.
that depression screen. Check that blood pressure. Make sure the diabetes isn't there. Then bring her back at 6 or 9 months. It could be a 10-minute visit. It could be a telehealth visit. It could probably even be a phone call for some. But it's
Right.
just making sure that people are staying on a path for health and they're not being lost in the cracks. And that's what I see a lot happen. Very many, just like with Tori Bowe, if you're alone, you don't have that system, is much more chance. And I don't know if she was, I don't want to say that, I don't know the circumstances, but I worry when people don't have a real network around them. So with that law passing, and we're here in Louisiana, they've had it as well, we have to see that our healthcare system is creating that path for people to come in. They open the door, let them in, and also provide care that encompasses what they need, not just
Right.
addressing mental health, addressing nutrition.
So maternal mortality is a spiral because if a mother dies, it affects the child who was born, and it affects the other kids in the home.
A whole family, a whole community really gets
know.
majorly is
So infant mortality goes up if the mother passes.
Yeah, we see a lot
somewhat.
together. We see a lot of moms and babies actually die because of something like preeclampsia, similar with Tori Bowe. We don't talk about it a lot. The news didn't mention that she was 8 months pregnant, so that was a fetal death. That wasn't an infant mortality; it was a fetal death. We barely talk about fetal deaths and how many babies are lost because of preeclampsia, hypertension, stillbirth. Really, stillbirth is a crisis in the United States as well, where before that baby has a chance, it's passing away because of a lot of lack of care, lack of access, and also these conditions. So absolutely they track together because many of the things that lead to maternal death can also lead to infant death. Now infant death is also, there's some things very social related like sleep conditions. So after preterm birth, that's the #1 cause of infant mortality. We would say there's birth defects are out there that, there's some things we could do to reduce birth defects. But another is safe sleep, which is a lot of our babies die from being rolled over, suffocated, not sleeping the safest environment. So that's a preventable that we should all be aware of. You don't have to be a doctor to, support a family and getting, getting
So be the
safe
advocate,
care.
be the change, be the person in your environment who can make a difference with maternal mortality. We'll be back next week. Don't miss the last show with Dr. Charlene Collier. Thank you. Jesus is Lord. Amen.